Good evening, everyone. On behalf of Intas Pharmaceutical Limited and Janet Division, I, Dr. Mithilesh Nayak, welcome you all to one another episode of Nephro Live. And today we have another interesting topic to dissect, that is the dialysis, a primer for physicians. So, what should we do when it comes to the dialysis? How physician can handle such cases, and how the post-dialysis care can be managed. So that we all are going to dissect today. And to guide us today, we are having with us our co-director for the Nephro Live program, Dr. Dinesh Kullar. He is currently Group Chairman, Nephrology and Renal Transplant Medicine, Max Healthcare Institute Limited. Uh, so with this word, I hand over the forum to Dr. Kullar sir and request him to introduce our faculty for today's program. Over to you, sir.
Thank you very much, Dr. Mithlesh, and thank you once again, Intas, for this wonderful initiative where over the last couple of years we have endeavored to spread the awareness about the management of chronic kidney disease amongst all our fellow physicians, doctors across the country, trying to help them as nephrologists as to what they all need to know so that, as we always say, by the time patient comes to us as nephrologists, it's too late. And I think most of the times the crux lies with the appropriate management with the first contact physicians and the people who are, of course, they are most comfortable with having shared a rapport over the years. And at times we coming in late for the management of this very complex entity called chronic kidney disease, we struggle to strike that kind of rapport and bond with the patients who so very often would turn back to their respective physicians and doctors to understand about the way forward. So to empower all our great physicians across the country. I can't thank Intas enough to start this initiative, which is those who have joined us in the past editions as well would testify to the fact has been a great one, trying to bring home the various improvements in the management of chronic kidney disease which have taken place over the last few decades, and certainly has made the task rather easy for us as specialists to be able to offer something very, very meaningful in the management of these patients. I've often shared this viewpoint of mine that till about a few years back, unfortunately, we didn't have much to offer to these patients. And it's now it's a matter of great pride that medical science has reached to a point where we can certainly say that yes, we have a lot of weapons in our armamentarium where we can effectively help slow down the rate of progression of this kidney disease, which we know is a progressive and irreversible damage. But yes, something which was happening in a very short span of time, we can now expect it to happen after many, many years with the kind of great weapons which, as I said, we have now in our repertoire. So, as we have always discussed in the past, that once chronic kidney disease happens, it's just a matter of time that eventually, if these patients live for long enough, they are going to unfortunately land in a stage where the life forward would depend upon either on dialysis or a successful transplantation. We will keep discussion on transplantation for some other edition, but today we are focusing on the dialysis, and I would want to bring home the point that dialysis is not a villain. Well, on one hand, we have tried to make huge improvements. We have added a number, we have now been able to add a number of years before these patients finally land up in a stage of dialysis. But eventually, as and when they do start requiring the need for dialysis, my request to everyone who has joined us today is please do not perceive dialysis as a villain. Now, dialysis is a friend and not a foe for our patients. It can live, it can offer a long lease of life to our patients, and it is not the longevity which matters. It is also certainly, it brings in a great quality of life as well. Something which was not possible till I would say a few decades ago. when I set about becoming a nephrologist, the reason why on a personal note, I would want to share was because of the magic which I saw in the process of dialysis. Patients about to die were able to live, and because of dialysis, within the first treatment with dialysis, the life would change from a virtually gone state where they were about to die, panting for breath. They would bounce back and live on with the help of dialysis. But one thing which was still irking us was that the quality of dialysis was not appropriate. We used to listen to success stories that people in Japan, people in Europe, and many other developed countries were living on dialysis for periods as long as 2 decades or 3 decades. Now that number has grown to something like 40, 50 years in countries like Japan. But our patients were not able to do that. And then we realized that the way we were doing dialysis was not the appropriate one. We were saving lives, we were able to prolong life a bit, but yes, the quality of life was certainly not what it was really desired. And secondly, the longevity was not there at all. But gone are the days. We have seen a great change in the way dialysis has come up in our country as well. And we can now boast that many of the centers across the country can offer top quality dialysis, state of the art dialysis comparable to the best anywhere in the world. And gone are the days when one particular episode of dialysis would be very a taxing job, a very dreaded experience, because we were using in the good old times something like acetate dialysis, a poor quality dialyzers, having not much of inclination towards offering top quality water for dialysis. But things have changed, and changed for definitely better. And now we can boast that majority of the centers across the country are able to offer dialysis, which is a very pleasant experience. We are now looking at survival of over 2 decades in our country as well. Very soon, I'm going to say that yes, in India also there are people who have survived for longer than 30 years, and sky is going to be the limit because we have learned the nitty-gritties of the best possible dialysis, and this is what we are offering. From, as I said, primitive dialysis, no heat to the water treatment, from low flux to high flux, from high flux to even the hemodiafiltration, which is the state of art dialysis, which everyone now acknowledges is the way forward, which has made huge difference. And to guide us about, or give us a primer about what dialysis is all about, we have Dr. Venkatesh. Dr. Venkatesh is a brilliant nephrologist from Max Healthcare Lucknow. He's the associate director there, and he did his DM from SGPJ Lucknow. And believe you me, in a short span of his tenure as a nephrologist, he has earned very wide recognition for his clinical judgment, for his clinical acumen, his academic abilities, and it's always a treat to interact with him when I have to discuss about patients, and he regularly contributes to our various forums. And as you can see, he has published numerous research papers. So this is about Dr. Venkatesh. And up next, we have a very dear friend of mine, Dr. Rajiv Anigari, who is a senior consultant in nephrology, Apollo Hospitals, Chennai, the prestigious one. He's been a teacher there, and he has keen interest both in hemodialysis, the critical care nephrology, something like CRRT, as well as in peritoneal dialysis. So he will probably be the best person to give us a holistic approach to a patient who requires dialysis, be it hemodialysis or peritoneal, because he's also done a fellowship of International Society of Peritoneal Dialysis. He's a reviewer for various journals, has a lot of publications, and contributed to various book chapters. So it's always a treat. Rajiv is certainly one of the most experienced nephrologists we have in Chennai, better known names, and certainly it's always a pleasure to interact with him with his vast knowledge. Up next, we have next one, please, Ms. Leish. We we then have are joined by Dr. Ravi Bantu, Dr. Shailesh Kakre. Dr. Shailesh is a senior consultant and head of Department of Nephrology at the Jupiter Hospital, Barnar, Pune. He did his training from CMC Vellore about more than 10 years ago, and subsequently he also got the fellowship of prestigious American Society of Nephrology. He's been trained in various aspects of nephrology and has close to 2 decades of experience working as a nephrologist, and he has experience in practically all aspects, the practical ones, the transplantation, be it the straightforward ones or the challenging ones, and a lot of work as far as dialysis is concerned. He has vast experience in the field of dialysis as well. Up next is Ravi, a very dear friend, and he works at PSRI, and we have a personal strong bond where Ravi and I have shared our experiences trying to help our patients in the best possible manner. A very astute clinician who takes a lot of good care for all of his patients, and a very devoted one, and has been the ex-vice president of Delhi Nephrology Society. He's also a fellow of ASN, and also he takes keen interest in various clinical trials, for his all abilities and contribution, he's been rightfully the recipient of various awards. And of course, PSRI hospital where he works is an active DNB teaching program, so he is a sought after teacher there as well, and has a number of publications. So I'm sure he's going to contribute a lot in today's discussion as well. Last but not the least is Dr. Preeti Meena, and I was before going live, I was telling the members who had the faculty who had joined, that Preeti has actually made Delhi proud, because Delhi was her second home, having been trained here at Maulana Azad, and then subsequently at prestigious Sir Ganganam Hospital. She has made Delhi proud by moving on to join as assistant professor at the prestigious All India Institute, Bhubaneswar, where she's doing a tremendous job, and I think it's always a treat. She's now best known for a very unique kind of initiative which she is now almost synonymous with, and that is the visual abstracts, which she makes so beautifully. And the moment you pick up any visual abstract in the top journal anywhere across the globe, I mean, I assume that this is going to be written by Preeti Meena. Before at times, occasionally, I get disappointed to see some other name, but mostly it is her name getting the credit for the visual abstracts, which means the depth of knowledge which she has while analyzing the various journals. And rightfully, she's also been given the additional responsibility of associate editor, IGN. She's also on the editorial board of so many, and very interestingly, she also is one of the founder members, I would say, of Women in Nephrology. That's a very nice initiative. People have tried to promote nephrology amongst women across the country, the Indian nephrologists. And she's a council member of Indian Society of Hemodialysis, and rightfully she's been the recipient of various orations, including Dr. K.N. Udupa, and numerous publications. So it's always a treat to listen to her, to go through her publications. And yes, so also I'm flanked today by great people. I am certainly honored, and I will now, without wasting any time, ask Dr. Venkatesh to start his presentation. And before I do that, I must acknowledge the tremendous help of Dr. Kulwant, my dear colleague at Max has Hospital Saket, who is the force behind helping me out with planning out the presentation, and of course, Dr. Mithilesh also from Intas, who have been instrumental in shaping and giving it the kind of a flavor the meeting has gained over the last couple of years. Over to you, Dr. Venkatesh.
Thank you, sir. Good evening, everyone. Are my slides visible?
Yes, they are. I think if you can move them. Yeah.
I thank Dinesh Kundla sir for giving me this opportunity. I'll be going through basics of dialysis today. So the contents will be I'll be concentrating on mechanism of dialysis, quality assessment, basic dialysis apparatus, dialysis prescription, and complications. So the mechanism of solute transport, like in dialysis, we have three transport. One is about small molecules, that is urea creatinine, and second is ultrafiltration, that is water. And when this water takes some middle molecules along with it, it is called convection. Ultrafiltration is dependent totally on transmembranous pressure, that is the pressure difference between the dialysate compartment and blood compartment. When we combine dialysis with convection, that is when we are trying to remove more middle molecules, through increasing the pressure in the blood compartment by infusing some fluid, that is called hemodiafiltration. So we have hemodialysis where there are two mechanisms. One is diffusion and ultrafiltration. We have one more mechanism, hemodiafiltration, where we have all three mechanisms going on. So basic principles of dialysis is, we have the dialyzer as shown here. We have the fibers here, hollow fibers, in which the blood will enter, and then we have a dialysate which is entering. The blood and dialysate are usually counter current flow. This is to maintain the gradient of urea and creatinine and other molecules across the dialyzer. So they move in opposite direction, and the pressure which is generated from the blood pump, when it's coming from the patient, the blood goes to the blood pump. The pressure generated by the blood pump will maintain the pressure to push the water out of the hollow fibers, which will create ultrafiltration. And the solutes move from the blood, which is highly uremic, which contains urea, creatinine, phosphorus, will move from an area in which they are high to an area of dialysate in which they are very minimal. So there are two processes, that is diffusion as well as ultrafiltration. So coming to the basic understanding of whether we are adequately dialyzing our patient or not, that is the first most easiest thing is extraction ratio. This is the function of the dialyzer. So it shows us like if the the blood which is entering the dialyzer, if it has a urea nitrogen of 100 milligram per deciliter and the exit urea nitrogen is 40 milligram per deciliter, we understand that extraction ratio of the urea is 60%. So if we increase the blood flow rate, more and more blood will be entering the dialyzer. It will go fastly through the dialyzer, so the extraction ratio will go low. But if the blood is going to stay for more time in the dialyzer, it is going to be in contact with the dialysate in which there is no urea. So if we decrease the blood flow, there will be higher extraction ratio. So coming to clearance of the dialyzer and K0A of the dialyzer. Clearance of the dialyzer is nothing but the extraction ratio of the dialyzer into blood flow, which is usually given in ml per minute. The main, when it comes to what we use clinically, is K0A. It is the diffusion capacity of the dialysate for a particular solute when there is infinite blood flow and infinite dialysis flow. We can calculate the K0A of a dialyzer from clearance as well as blood flow from this hologram. The usual dialyzers which we use these days are high efficiency dialyzers, whose usually K0A is more than 800. And not only the K0A, the other parameters which on which the clearance of a molecule depends are molecular weight and whether the molecule is predominantly distributed inside the RBC or within the plasma. Urea is freely diffusible. So easiest molecule to be cleared by dialysis is urea. Efficiency of a dialyzer is basically K0A of the urea. And we have classification of dialyzers basing on that. If the K0A of urea is less than 500, we call it low efficiency dialyzer. If it is 500 to 800, we call it moderate efficiency. And if it is more than 800, we call them high efficiency dialyzers. So the clinical side, what tells us whether the patient is getting dialyzed adequately or not is urea reduction ratio and KT by V. KT by V is derived from K, that is urea clearance, T session length, and volume of the distribution. So when we are this is derived from urea reduction ratio. Urea reduction ratio we will get from patient's pre-dialysis urea and post-dialysis urea. Usual decrease of the urea in a dialysis session is 60 to 63%. And when and that 63% for each session contributes to KT by V of 1 for each session. Then if this KT by V not only is takes care of urea reduction ratio, but it also includes ultrafiltration, which we are doing. So if we increase the ultrafiltration, obviously urea reduction ratio is going to improve. And then there is something called as KT by V per week. Each patient is on twice or thrice a week dialysis. So we get KT by V from urea reduction ratio. And then when we take this KT by V of single pool, that is single dialysis, and when we combine it with the frequency per week, then we get the standard KT by V. So usually the guidelines are based on standard KT by V. Then comes what is dialyzer efficiency and dialyzer flux. Till now what we have listened is about dialyzer efficiency, which is mainly urea clearance. When it comes to the flux, it is mainly for middle molecules, that is convection based clearance. So this is of the pore size rather than area. While dialyzer efficiency is about surface area of the dialyzer, the pore size determines the flux of the dialyzer. Flux is how much water can be filtered through the dialyzer per hour per each mm of mercury, for each mm of transmembrane pressure. Low flux dialyzers usually transport more than 20 ml per hour, less than 8 ml per hour, while high flux dialyzers transport more than 20 ml per hour. So routine dialysis, which we use in routinely, are high efficiency, low flux dialyzers. While in HDF, hemodiafiltration, we use high efficiency as well as high flux dialyzers. So coming to the dialysis apparatus, what is dialysis apparatus? One is blood circuit, second is water purification system, third is proportionating system, and then conductivity monitor. So these are typical connection of the dialysis. From the arterial side, the blood goes to the pump, and from the pump, it enters the dialyzer. And from the dialyzer, here we can see the dialysate inside, which is counter current flow. And then the blood enters through the dialyzer, and then it exits through this, and it enters the venous chamber. From the venous chamber, the blood enters back to the patient's body. So if we see the circuit, we have three. This is the pump. This is the main part of the dialyzer, is the pump, which generates the pressure across this pipeline to maintain the ultrafiltration. So we can see once the blood is crossing the pump, the pressure inside the circuit is increasing. And once the blood crosses the dialyzer, again the pressure drops. So this positive pressure is the one which maintains the ultrafiltration within the dialyzer. So dialyzer, now what we are using is hollow filter dialyzers. This is a usual dialyzer we see, and the usual membrane that is used in India is polysulfone dialyzers. When we take the cross section of the dialyzer, this looks like this. These are the multiple fibers through which the blood enters the dialyzer, and this white part will be the dialysate portion. So here we can see the multiple fibers, and then through these membranes, the blood, the urea and creatinine and other molecules enter the dialysate, and from there they go into the efflux. So dialysis water and dialysate. So how is dialysis water prepared and how is dialysate prepared? It comes through like this is the most important part of the dialysis, because each patient is exposed almost to 120 to 200 liters of water per session. If there are any mineral contaminants or endotoxins, that will affect the patient's life. So recommendation is usually the quality of water for routine dialysis should be less than 100 colony forming units per ml and less than 0.25 endotoxin units per ml. How is this achieved? Initially, we dialysate water is prepared through RO unit, where the water goes through a softener, which will remove the chlorine and this thing and carbon, and then the water goes through reverse osmosis, RO system, where almost 95% of the contaminants are removed. And then this water goes into loop system. From there, it is distributed to each dialysis machine. This water is mixed along with the part A and part B of the dialysate within the machine's internal hydraulics, and the dialysate is prepared. So the water is prepared from the RO unit, which is supplied to the dialysis machine. The dialysis machine prepares the dialysate internally through its mechanics. So within the machine, we get a part A, which is acid part, then part B, which can be in the form of powders, which is usually mixed at the dialysis center into cans, or now the one which we are more commonly using is sodium bicarbonate bags. And then along with the water, the dialysate is prepared, which is usually in the proportion of 1 acid part and 1:8 base, and 34 parts is water. So when we see the final composition of the dialysis, which is used is sodium of 135 to 145. Potassium is usually maintained between 2 to 3. and calcium is usually 1.25 to 1.75. Bicarbonate is around 25 to 35. This is the usual final dialysate. So coming to the prescription of the dialysis, what all should we mention in the dialysis prescription? What dialyzer we want to use, what is the blood flow that we want to use in the pump, and then what is the dialysate flow, and net ultrafiltration that we need, and any changes in dialysate composition, and what should be the duration of the dialysis. So when it comes to the dialyzer, how to decide the size of the dialyzer for a patient? It is dependent on the surface area of the dialyzer. Each dialyzer has a surface area, and the surface area of the dialyzer should be smaller than the surface area of the dialyzer must be smaller than the surface area of the patient. So usually if we calculate the surface, most of the adults we use F6 or F7 dialyzers. F6 to F8 are the usual dialyzers in adults, while F2, F3 and F5 are for pediatrics. And usually for acute settings, we use low flux dialyzers, which is I have shown they are low flux high efficiency dialyzers, while in chronic, that is for which has optimal for better middle molecule clearance, where we want to do chronic dialysis. Optimal is to use high flux dialyzers that are hemodiafiltration. Coming to the duration of the dialysis, in acute, usually we have two types of dialysis. One is intermittent dialysis, which is 4 hours. But usually in acute dialysis, it is difficult to achieve KT by V in ICU settings because of multiple reasons. One is breakdown of the dialysis due to hypotensions. Urea and creatinine usually sequestrated in the muscles. And then volume, these patients are usually volume oriented. And again, the catheters sometimes will not provide optimal pressure. So usually in ICUs, we prefer to do more intensive dialysis and more prolonged dialysis, like 6 to 12 hours. And it can be done daily or on alternate days depending on the need of ultrafiltration and clearance. While chronic intermittent dialysis is usually typically intermittent hemodialysis, which is done usually for 4 hours in a dialysis center. Except for first 2 or 3 sessions, we usually use first 2 to 3 sessions. We do 1.5 to 2 hour sessions to prevent dialysis disequilibrium syndrome. Coming to 3 important terms in dialysis prescription. One is QB. QB is blood flow, which determines the clearance, which I have shown in the initial slides. Usually we in acute dialysis, that is in ICU settings and inpatient stay, usually we use it from 180 to 250. In chronic, it can be from 220 to 300 ml per minute. And dialysate flow, that is QD, is usually 1.5 to 2 times that QB to ensure maximal clearance of the blood that is coming into touch with the dialyzer. And ultrafiltrate, usually comfort zone is 10 ml per kg per hour. Even we can go up to 15 ml per kg per hour, but it might land up in hypotension. Complications that we usually see during dialysis include hypotension, intradialytic hypertension, and then cramps, headache, and intradialytic hypertension, and vomiting and pruritus. Most common complication is intradialytic hypotension. The most common reason for this is large intradialytic weight gains or short weekly dialysis or targeting excessive dry weight. Or if there is inadequate vasoconstriction from the patient side due to high dialysis temperature or autonomic neuropathy of patient, anemia, or cardiac factors like whether he has systolic dysfunction or diastolic dysfunction. To prevent hypotension during dialysis, it is better to use temperature of 35.5. Patient should try to restrict the salt. We should try to improve the urine output through residual renal function. Extend weekly dialysis period rather than like doing it 3 per week. And in refractory cases, we can use high sodium, but this might increase the high interdialytic weight gain because there will be increased thirst for the patient. And it is always better to optimize hemoglobin to 10 to 11. Despite this, if we don't have, if the patient develops intradialytic hypotension, we can try midodrine and sertraline. Thank you.
Well, thank you very much, Dr. Venkatesh. That was a very, very comprehensive and a nice overview of what we truly believe every physician should know about the process of dialysis. As I said, it so many times it's wrongly labeled as something which is very, very toxic for the patient. very, very difficult to tolerate for the patient. But I would like to reiterate a few of the points which you have already beautifully made, and that's something reiterating what I said at the outset. We've come a long way. We have, and you actually talked about that journey, talking us about what good, effective water treatment is all about. And we do understand the huge importance because, as you had said, the body is exposed to so many liters, over 120 liters of water in a particular session. And you look at what can happen if you bombard the human body with that kind of toxic agents over a period of time. Yes, just to make it easy for all those who have joined, dialysis is a process where we are typically taking the help of the process of diffusion. We know that the blood is rich in impurities like urea and creatinine, and while that clear normal fluid which we have traversing on the other side called dialysate does not have any impurities. By the process of diffusion, whatever is more in blood comes out into the dialysate and down the drain. And there is an equilibration of the kind of balance which we want to maintain. The blood is rich in potassium, so many other electrolytes, which we can have the desired amount on the other side. And the two do not come in direct contact with each other because there is a semi-permeable membrane. So this is about diffusion. We can always go back to our physics classes and learn with that kind of excitement as to what we did then. But this is not the only things we have. Over a period of years, we realized that diffusion was taking care of small molecular impurities like urea and creatinine. But yes, they were being able to take care of the immediate insult, the acute insult in the body because of the cessation of the kidney function, and we were able to remove those immediate things which were giving rise to those uremic manifestations. But over a period of time, what did not allow these patients to live long and have so many ill effects on the heart, on the bones, on the other body systems was the inadequate removal of middle molecules with the help of diffusion. So in comes the concept of convection, and we realized with the help of the high flux membranes, whereby we could achieve that. And then finally, we now have that beautiful paradigm shift away from the conventional hemodialysis to more and more in favor of hemodiafiltration, where we are employing the best of the two worlds, diffusion as well as convection. And I often use the analogy of saying that दो डाला means कि आपने एक bucket पानी का उठा के you actually put it directly into the bloodstream. So you are actually infusing the dialysate, the pure dialysate, ultra pure dialysate directly into the body and into the blood, and then removing the extra through ultrafiltration. By this way, by convection, along with the drag of the water, the higher molecular weight, the middle molecular weight toxins also get eliminated. Something like beta 2 microglobulin, because we talk about beta 2 microglobulin because when we know that we have removed something which has a molecular weight of about close to 12,000, we are in the bargain also removing many of the other middle molecules which were having ill effects on the body in the long run. So now hemodiafiltration gives us an opportunity from shifting from hemodialysis to hemodiafiltration, employing both diffusion and convection to help. But the real difference to my mind was when we graduated up from low flux to high flux, from acetate dialysis to bicarbonate dialysis, from the kind of importance we are now giving to water quality. So these are the discussions which I'm quite excited to have with the elite panelists who have joined us today. And I'll start by requesting Dr. Rajiv Anigeri as to start from the absolute basics. Over during the last few editions, we had discussed as to what various stages of CKD are, starting from the early, that is stage 1, to as advanced as stage 5, and stage 5 is when GFR has fallen to less than 15, and we start talking about initiating dialysis in these patients. But Dr. Ajiv, to make things easy for those who have joined us today, at what GFR typically would you want to subject your patients? And mind you, audience, we are talking about chronic kidney disease. We are deliberately not discussing acute kidney injury today. We have already done that, and we can in our subsequent editions. But let us focus on a gradually worsening kidney function, reaching to a stage whereby the nephrologist will say, okay, enough is enough, and we have to subject the patient onto dialysis. And there's a whole lot of myths and unfounded fears revolving that. Patients, as I said, will always go back to their primary physician, and unless the primary physician is empowered to know what great effects can dialysis have on the effects of a given patient, they will also at times wrongly be discouraging these patients from going ahead with such a great modality. But yes, it comes with a lot of experience, and that is why I'm asking a very experienced nephrologist such as Dr. Rajiv to let us know as to when does he subject his patients on to dialysis, any variety, be it hemodialysis, what we have discussed, and there's another modality called peritoneal, which we may discuss, or if time permits, we can have some discussion around that, or maybe we'll do it the next time. Dr. Rajiv.
Yeah. Thanks, Dr. Dinesh and Intas for this kind invitation. It's a pleasure to be part of this wonderful program. Basically, we have to prime the patient even when the patient has a GFR, say about less than 30 ml per minute, or when the patient enters CKD stage 4. I think we should start priming them for the eventuality of going on a dialysis. And if your primary physician taking care of this patient, this is the time they should refer the patients to the nephrologist for the creation of fistula. And my understanding is that you're asking me to how to prepare. Is that right? Or yeah.
That's one. And when to actually finally initiate them onto, is it just a number of creatinine which comes to your mind, or the total manifestation of uremia, what we call as? Yeah.
Yeah, the first step would be to get the fistula done. It doesn't mean that at 30 GFR you should be creating a fistula. You should be probably observe them closely. And one of the important factors is the trajectory of CKD progression. You have different trajectories, and those who have a very rapid progression, I think you should be much more cautious in what you call recommending AV fistula. Generally, AV fistula I recommend around GFR less than 15 ml per minute. And initiation of dialysis is a very clinical judgment. It is not what you call objective sort of thing. And generally, if you have a GFR less than 6, even if you have no uremic symptoms, I think you should subject them to dialysis, because if you do not do it, the possibility of there is an increased risk of death in the post dialysis situation, maybe 3 months or 6 months. So GFR 6 is the absolute cutoff for initiation of dialysis. Between 6 to 10, I think, is a clinical judgment. You have to look for the uremic symptoms. What are the uremic symptoms? Very obvious ones are very decreased appetite, nausea, vomiting, and uremic pruritus, and of course breathlessness, which is not responding to diuretics. And not so obvious ones are the ones which have a slow progression of what you call a malnutrition and frailty appearing. In those patients, I would rather start dialysis a little bit earlier. So if you get the answer, less than 6, absolute indication, 6 to 10 based on the uremic symptoms, more than 10 if you have a uremic symptoms or what you call progressive worsening of nutrition as well as frailty, which is worsening. Many of the patients really reduce the intake of what you call this food, and they become frail. And the GFR, if you lose a muscle mass, your GFR may not actually change because of loss of muscle mass based on the creatinine. So you should be cautious in those patients. I hope that answers your question.
Yeah, so I'm going to come to Dr. Shailesh also taking his viewpoint. But before that, Dr. Ajit, you've raised a very important point, educating the people and the families to ensure that we get the AV fistula created at the right time. We all know that obviously making the patient sit in front of a dialysis machine is not going to help. We have to hook them onto the dialysis machine. How do we do that? So, and Dr. Rajiv, in your experience, how often do they comply with your instructions and get an AV fistula created? And what is the biggest reason as to why they do not get it created?
So even though I mean, tell the patients about this dialysis, in fact, most of the patients do not get a fistula created unless it's very late, and when they start getting a little bit of symptoms, and this is the problem. They have a great fear of entering into the unknown territory of dialysis, and even the thought of entering dialysis with this kind of things, this one plays on their mind. But I think you have to emphasize the fact that delaying fistula too late is more problematic. So if you ask me honestly, what is the number of patients who I've been following? Maybe 35%, maybe 40% do get the fistula at the GFR of 15, and most of them get maybe around 10.
Dr. Ravi, this one is for you before I come to Dr. Shailesh. Ravi, as Dr. Rajiv is saying, majority of the times patients don't listen to us. They have unfounded fears. They don't get an AV fistula created, and the inevitable does happen. They finally land up with you and requiring an urgent dialysis. So what are the ways you would initiate dialysis in these patients at this point in time when they don't have a functioning or a fistula which is yet to be created? And mind you, for those who are not initiated, AV fistula is joining the artery and the vein, typically at the wrist, where you take the help of radial artery and the cephalic vein. If the veins are not suitable at the level of the wrist, you go up at the level of the elbow and you join the brachial vein artery with the cephalic vein, or you transpose the basilic vein to come nearer the brachial artery, and this is how you create. If the vein is not there, the the vessels are not suitable, you go in for an AV graft. So these are the two permanent kind of vascular excesses which you have in mind. But my question to Dr. Ravi is, supposing they don't come, they don't listen to us, and that's the so frustrating at times for us as nephrologists. So Ravi, how do you initiate dialysis in your patients?
So actually, even if we consult the patients at appropriate time, generally less than 10% would go for fistula before they are almost imminent to go on a dialysis. Now we have to understand that to do dialysis, the blood in the machine has to rotate very fast. That is 200 to 300 ml in a minute. So now this amount of flow we cannot achieve from the peripheral veins where we use the IV cannula to give drips, or so we only there are four sites in the body. One, two is the jugular subclavian on both sides, and two is the femoral on both sides. So these are large veins in the body from where we can take out blood at that speed and return also. So now once the patient does not have a fistula which can provide a high flow, so we have to cannulate these veins, and that is done with the help of temporary catheters. If the patient is in a good condition, you may go straight for a permacath insertion, which is a better method because the risk of infection is less. It is a cuffed catheter which is put into the internal jugular vein. Or if the patient is not in such a fit condition, then you may have to insert a temporary catheter where you have to again insert it ultrasound guided. You can insert in the jugular vein or the femoral vein if patient cannot cooperate. So in that condition, these temporary lines help us to start dialysis immediately. Just put the line and you can start immediately.
Very nice, and I think very good way of explaining, Ravi. And for again the listeners who have tuned in today, what Dr. Ravi was talking about is employing those large veins where we can put in catheters. And again, the catheters are of two varieties. One are the non-tunneled ones, the temporary ones, which can typically be used for maybe 2 weeks, 3 weeks, or up to 4 weeks, and then invariably they either get clogged or they get infected. So that's not a great thing to happen in our patients who are already weak, debilitated. We don't want to see any episode of infection in them. But unfortunately, they have fallen in that trap because they were not wise enough to listen to us to get an AV fistula created at the right time. But what we have now learned is rather than using a non-tunneled tunnel catheter, which can be done within no time in the dialysis unit itself, we would rather take these patients to the cath lab or to our radiology room, and then taking the help of imaging, put in a tunneled catheter, which is a much better refinement, and a catheter which typically used to stay for just about couple of weeks, 3 weeks, now can be made to last for almost like 6 months, 1 year. At times we have many success stories where people don't want to get their tunneled catheter removed for periods as long as 4 or 5 years. That is something which we never advocate. But then our main aim is to take care of the next 6 months or 1 year, during this period, patients would have decided whether to continue on hemodialysis or move away from it and go in favor of kidney transplantation. My question to you, Dr. Shilesh, is Dr. Rajiv said, yes, you have the GFR in mind and you have you have the manifestation, uremic, the symptomatology in mind. What, in your experience, is the right way forward? So many times patients come to us and the creatinine of 10, 11, GFR is hardly 5 or 6, and there are no symptoms. So what is your take on early dialysis versus late dialysis? Would you want to draw a line that, look, I am not going to tolerate any creatinine beyond 10 or 11, any GFR less than 5, or maybe you'll say, I'm keeping a close watch, maybe at the slightest hint that the patient is having any symptoms. And mind you, those people who have joined us today, it is not just about nausea and vomiting. A very subtle way of knowing that your patient is becoming uremic is the loss of muscle mass, patient becoming thinner and leaner and getting debilitated, and you realize it. By the time you realize it, it at times is so late, and by the time they get initiated on hemodialysis, it is actually a very weak patient being initiated on hemodialysis or any form of dialysis, and then it'll actually bring more bad name to the procedure, saying that it happened because of dialysis, and I would rather put it as it happened in spite of dialysis. So Shailesh, over to you, please.
Hi, good evening. Uh,
Good.
Thank you, Bhula sir and Intasti. I think you have answered my question also. The whole thing is, I think Raju sir also told the same thing that if the GFR is less than 5 or 6, I think we have to initiate dialysis because later on there will be consequences of it, and patients may have, after starting dialysis, they may have a problem. Adding to the point which you have already told about the weight loss, it's a very important point. I think everybody should look at the regular basis the weight of a patient, because weight loss is one of the important symptoms which people miss. The problem happens in the weight loss is only when they are edematous as well. So the edema actually takes over and the weight is same, and the patient are having malnourishment. So the malnourishment has to be seen at a proper level. If it is there, I think we have to initiate dialysis. And in loss of weight, vomiting, nausea, these are all the symptoms. But yeah, once we are following up the patient regularly, we can actually make out, yeah, this patient is not doing well and we should initiate in dialysis. Numbers, definitely, I don't go by numbers only. That with the creat of 10 also, I have a patient who are doing without dialysis and they are asymptomatic, not having any symptoms. So we wait, but we have to create a fistula and tell them that as soon as the time comes appropriate, we have to start, and as soon as GFR declines or any other further symptoms, the most of the times I seen they have got some other problems, and then there is they have to initiate dialysis at such patients.
Dr. Shailesh, very pertinent points. But then another, Dr. Rajiv, a point which Dr. Rajiv had alluded to, they stop taking proteins. They would rather
That
have a
is
lower urea value. So what is your advice to these patients
my
in terms
advice.
of diet?
My advice is very clear that you should not lose weight, basically become malnourished. Protein intake in Indian scenarios are actually we don't take that much high amount of proteins anyway in our diets. So my advice is always that please keep your diet zero point 0.8 to 1 gram per kg, whatever is the regular thing, that is enough to keep our muscle mass. But people are really malnourished. They don't eat any protein once they come to know that they are having CKD. So my usually advice is them to please have proteins, but yeah, you have to measure. If anybody is really having high protein intake, then they have to decrease the protein. Otherwise, I think I ask them to continue the regular diets.
So, Preeti, this one is for you. Dr. Shailesh has given a general view of all kinds of patients. But my question to you is limited to the elderly population. You see, it's a big dilemma in anyone's mind. A person, there are two kinds of elderly people in their, I would say, 80s, late 80s or early 90s. Now, the two kinds, one would be typically a bedridden old person where hardly any muscle mass, and you are quite hesitant in subjecting such a patient onto any kind of dialysis for the fear that it may actually aggravate the problem and put your patient in a difficult situation. Vis-a-vis a patient who is like having daily morning walks, is even doing joggings on every morning, um, uh, even though he or she is in her early 90s. So, what is your approach to such patients? Would you want to delay dialysis in them or start them at the right time? Because age, what is your take on age? Is it a relative criteria, or you will say no, no dialysis after 85 for anyone?
No,
No, nothing like that.
thank you for the question. I think it's a very important question. As we are discussing about when to start dialysis, the indications of dialysis is similar as what we had discussed. And now, when there's a age factor is there, it is not up to us as a nephrologist what we want, whether we want to initiate dialysis or not. We had discussed about when should we initiate dialysis, but now it's on the relatives and the patient what they actually want with their life. If they come to you, we are telling them that yes, it is the stage you have to start dialysis because you're getting the symptoms which we had discussed, like volume overload, hyperkalemia, which could be dangerous, metabolic acidosis, the hardcore symptom. It is really needed and you have to go through it. And at the same time, we have to tell them what could be the risk, what could be the consequences, both benefits and risk. And it is now family's decision whether they want to go ahead with the dialysis. We can offer them both the modalities of dialysis, hemodialysis, peritoneal dialysis. They can choose they want to do it at home. We can supervise them, we can teach them. If they want to do it, they can do it at their home. Or if they are healthy and if they have the facilities, nearby centers, they want to go to the center and do it, they can go ahead. It is actually their decision. We had decided what are the indication. We go as per those indication. Patient is malnourished, is not eating, is volume overload, is hardly respiratory, it is high, respiratory distress is there, then patient has to go dialysis as per us. But now it is up to patient and the relative. So it's basically a shared decision with the family.
Points well taken. I think who are we to play God? And I think it has to be a collective decision. So I would totally agree, unless someone else has a different viewpoint, that age is just a number. And I think we need to look at how that particular person has been in the recent times. If someone was doing quite well, and it is just because of the advanced uremic state that that person is not doing well, I think we have all the reason to initiate such a person on dialysis. And then comes in what where to start it. And you've raised a very important point, whether to do it in center or make it happen at their respective places. So hemodialysis, mind you, can be done at patient's own. We can create the situation whereby they can have a permanent way of doing dialysis at their respective places, or we can have periodically a machine sent to their respective places to do it for them, so that to make things easy, especially those who cannot easily travel. But the other form of home dialysis is what we typically refer to as peritoneal dialysis. For want of time, we didn't elaborate on peritoneal dialysis today, but then I think maybe we'll do it subsequent times. But just a brief, whereby whatever we were trying to achieve with the help of dialysis machine, the same we can do by employing the human body itself, which means the peritoneal membrane you can be viewed as that semi-permeable membrane, and on one side of it is the blood circulating, and on the other you instill the peritoneal cavity, you instill peritoneal dialysis fluid into the peritoneal cavity, and the two do not come into direct contact with each other, and the peritoneal membrane acts as the semi-permeable, and you can achieve the diffusion and the ultrafiltration with the help of body's own peritoneal membrane, and it does wonders. Unfortunately, India has lagged behind. There are countries who have taken a lead, countries such as even Hong Kong and Thailand and Mexico or England, where so many times we have PD as the first policy. You are bound to go on peritoneal dialysis as per the state's wishes. The government funds peritoneal dialysis, but there are many factors which do not allow peritoneal dialysis to be done as frequently in our patients. We know that close to 200,000 people get into the stage of requiring dialysis, new patients every year. and just about 15,000, 12 to 15,000 patients can undergo kidney transplantation on a yearly basis in our country. The remaining have to survive on dialysis. Well, the finances do not allow even hemodialysis most of the times, but most of the patients actually go in for hemodialysis. Just we in India, we have only mere 6,000 to 6,500 patients surviving on peritoneal dialysis, and the majority, I would say 95% plus, are on hemodialysis. What are the factors behind it, Dr. Rajiv? If you have vast experience in both the modalities. Number one, do you believe that peritoneal dialysis is a good modality? That's point, because let's try to tell apprise the audience of your experience, personal experience, and if you believe it is, then why is it ailing?
Yeah, thank you. See, it was 25 years ago. I was trained both in Toronto as well as Columbia University, Missouri for peritoneal dialysis, which are pioneering institutes for the PD. Initially, very enthusiastic about PD, but definitely it has waned over a period of time. And as you know, that only about 6% of dialysis patients in India are on peritoneal dialysis. And is PD first policy is the one universally accepted? No, definitely not. And there are government agencies and some of the centers push it as a first line, but I'm not really sure that I agree with that. The problem with PD in India is that the outcomes beyond 3 years are not good. This has been our experience. I don't know, others may differ with that. And moreover, it is sorry. Moreover, it is generally concentrated in places where it is an institutional practice is there. Individuals are not really into the peritoneal dialysis, and there are a lot of barriers to that. One is that patient themselves, they are fearful that infections are a problem. Sorry. Yeah. Uh, Other important issue that even the physicians, this is not in the very what do you call incentives are not there for the physician because patients daily drift off and do what their own thing. One of the reasons why they do not do well is that patients are not compliant with the dialysis as such. But having said that, I really recommend the PD as a first policy in patients who are elderly, maybe 60, 65, and who have a cardiac disease or what do you call severe comorbid conditions. I think they are the ones who really do well, at least in the first couple of years. And beyond that, I give an option to all the patients, basically everybody, that this is the things this can do, this is what we this one. Most of the patients do not accept PD as the first dialysis, mainly because they have seen the hemodialysis progressing so well, having such a good results, especially with the newer techniques like HDF. I think it's not a great, what do you call, a choice for the most of the patients. I may be biased about it, even though have a great enthusiasm for peritoneal dialysis, trained on it, but the enthusiasm definitely has gone down. Having said that, there seemed to be a resurgence of PD in patient in the Prime Minister's national dialysis program, and it is given only for the people who are below poverty line. My understanding that even those who get it, they are not really well trained and their outcomes are not that great, and the infection complications and other things are not really optimal. So we are doing it, but are we doing a great job in those patients? I'm not sure. Personally do not involved in that. My understanding is it is not a great results in these patients. Others may contribute to this,
Yeah.
whatever
So
discussion.
this is kind of a sad story, I would say. A great modality of treatment, which has actually not had too many takers. Dr. Rajiv's institute, Apollo Chennai, has been spearheading the campaign as far as peritoneal dialysis is concerned across the country. And talking from a personal experience, one of my patients crossed 21 years on dialysis. Peritoneal dialysis, not even a single episode of peritonitis. Unfortunately, he had chronic sclerosing peritonitis, whereby out of compulsion we had to stop, and he's still surviving on home hemodialysis. He's migrated now to Canada with to stay with his children, but then he's done well for good 25 years now on dialysis. I can recollect at least more than 12 patients who have survived for longer than 10 years on peritoneal dialysis, not even one episode. This gentleman who survived for 21 years, his own brother survived for good 17 years. So I think it's the way you educate them, the way you this thing. But then certainly the message which I wanted to convey, and I'm glad to announce that we have close to 1,400 people who have joined us today already, is that peritoneal dialysis is associated with many false notions and myths and unrealities, whereby people believe that, oh, a catheter is going to get placed in your abdominal cavity, peritoneal cavity. It means sure shot infection, when the answer is to the contrary. We've had huge success stories, and please, before making a decision, I would request everyone to give peritoneal dialysis a fair chance, whether we should be advocating this or not. But then coming back to hemodialysis, one area which we need to understand is that we typically start hemodialysis, let's say at a GFR about 10. Even at this stage, patient is passing good amount of urine. With every passing session of hemodialysis, with the ups and downs, the blood pressure falling, etc., whatever residual renal function was there seems to get lost. So, Dr. Shailesh, the question to you is, how much of importance do you give to this residual renal function, and what strategies do you adopt to preserve this as much as possible?
Yeah, so residual renal function is definitely important. I think whoever has a residual renal functions do definitely well, because there is electrolyte balances, there are fluid balances, which definitely helps them. So I think whatever measures which we have to take, like avoiding them to take any NSAIDs or have some medications also, that is one of the general precautions we should ask them. And the other thing is regarding the dialysis, I think we have to continue the dialysis as required for them. Peritoneal dialysis definitely is a better choice to preserve the residual renal function. But if they are already on hemodialysis, I think these are the things. But there are certain situations where we are actually held that whether we should really look at residual renal function, or we should go ahead if they have a history of some where they require a contrast, which is very important for them. I think then I allow them to do that, because that is more important for them than the preserving the renal function at that time.
So, Dr. Ravi, taking it from what Dr. Shailesh has said, if you were to be wanting to preserve residual renal function in your patients, could you enlighten us about the concept of incremental dialysis, whereby you have that in mind and keep into consideration the patient's ongoing GFR as well, while deciding as to how often they should come to you for dialysis. So, what is this concept about incremental dialysis?
So residual renal function is very important. The reason is that middle molecule clearance is maintained, even large molecule clearance is maintained by urine, which is not achieved by hemodialysis. Then also there is a sustained daily clearance, while the hemodialysis is intermittent. So these two advantages are there, and a lot of studies, even hemo peritoneal, have shown that patients having residual renal function survive more. Now, how to preserve it? Hemodialysis, as has been shown in the previous speaker, that the blood pressure, most common side effect is low blood pressure or high blood pressure, and this harms the residual renal function. Then the notion that we can safely use IV antibiotics like amikacin or Vovaran or painkillers in these patients can actually lead to early fall of this residual renal function. So we have to be careful. And incremental dialysis means that we can give lower dose of dialysis. That is not starting with the standard thrice a week, which is recommended. But we can, if patient has a residual renal function, we can start with once or twice a week hemodialysis or shorter hemodialysis sessions with a lesser ultrafiltration, so that there will be less hemodynamic change during the dialysis, and your urine output will be preserved. The amount of work the kidneys are doing will be preserved. So this is a very valid concept, and probably now it's coming into light by Western studies, but we have been following it for long, many years. Though the reasons may be different, the reasons may be economical, so
Yeah.
the patients are not affording. But then also it is actually a good concept, and it should be considered in our patients.
Dr. Preeti, this one is for you. I'm sure you would agree that we lose majority of our patients to, if not to infections in India, but to cardiovascular disease across the globe, including India. So, and they typically have a very high incidence of new onset heart failure or worsening of the pre-existing heart failure. How do you manage this aspect of their disease entity in dialysis? Because if you know that they can fall in the trap of heart disease, what kind of precautionary measures do you take in these patients? That's point number one. And secondly, how do you assess the volume status in these patients as to how much of fluid has to be removed, because patient needs to be guided. They will come and would have gained either 1 kilo between the two dialysis or 3 kilos. So how do you assess their dry weight? Maybe you can begin with this and then come on to how do you take care of the heart of these patients.
So yes, heart failure is one of the very important cause of death in a CKD patient. So first of all, I would start with saying the very strict salt and water restriction in these kind of patients. So if they're taking lots of water and a lot of salt, they would coming to us with recurrent heart failure, pulmonary edema to casualties. We actually see it in our casualty that every day some patient is coming, mostly heart failure, coming the heart failure. So we should there are a lot of studies also which says that increasing the sessions of dialysis in the week, for example, we can go from 3 to 4, or if possible nocturnal long hemodialysis. So this decreases the LVH chances of LVH and cardiac mortality in these kind of patients. But yes, we do have fear of RRF and AV fistula when we increase the sessions of dialysis. But first, I would start with the salt restriction and water restriction. There are some drugs, for example, beta blocker have shown to be better for prevention of heart failure and cardiac mortality. So I would change the drugs also. Sometimes ARNIs are now also prescribed, or increasingly prescribed by cardiologists in these kind of patients to decrease the mortalities. But potassium could be the issue. So I would go with the beta blockers. Sometimes the drugs like RAS inhibitors also, when we give them for hypertension, these also have to be proven the cardiac mortality benefit in our ESKD patient. After that, increasing the dialysis sessions in this patient. Coming on to the dry weight measurement in these patients, we use the common features which we use. For example, pedal edema is there, the Kirby line on auscultation. If crepitations are there, we would assess the volume assessment with that also. But now with the increasing use of POCUS, we can see the IVC diameter for the accurate assessment of diameter, and then we can advise fluid removal in these kind of patients.
How often do you resort to tools like bioimpedance?
In my center, I am not using bioimpedance
Right.
nowadays.
So many centers would actually be relying on this thing, because that makes the job of the technicians rather easy. The doctor doesn't have to be there all the time. You just assess the dry weight based on what Dr. Preeti has said, clinical examination, and then you say based on focus or bioimpedance that look, given in a given patient, the dry weight has been estimated to be 60 kilos. So that the next few times, whenever patient comes with whatever gain over and above 60 is removed typically with the help of ultrafiltration in the dialysis. But supposing the patient is gaining too much, we need to tell them to restrict their salt and liquids. And then what we also have to realize is that over a period of time, we do expect that whatever body weight they had lost on account of the process of the disease of uremia, will actually stand to be the patient stand to gain that much of weight. So we need to differentiate between the dry weight and the wet weight, which typically is the water. We remove only the extra water and not attempt to remove the patient's own weight, because that will give rise to cramps and make the life miserable. So Dr. Shailesh, the question is for you. What kind of dietary, because when I say that we want the patients to gain their weight, what kind of dietary recommendations do you have for your patients once they are on dialysis?
So once they are on dialysis, I am very clear with them ki you should have your regular protein intake should be definitely good, and it should be around 1.2 grams per kg per day. So if you ask particular things that vegetarian diets, I think we allow them most of the protein in the intake, like only the because of the phosphorus milk products can be depends on that we can actually restrict little bit, but otherwise I think protein intakes can be taken. Regarding protein powders, if they are okay to take that thing, I am okay. If some people have some problems with the taste and all, so I first focus them on the dietary supplements and then only go for supplementary supplements in the diet. And
Yeah. So,
regarding the fluid, I think we are very clear, and the potassium balance should be definitely there. So we have to tell them that you can't have the higher potassium. So fluid restriction, salt restriction, potassium restrictions are the most important thing. Otherwise, I think they should be allowed
yeah.
to have the good dietary protein intake.
Absolutely fine. I think spot on. All the panelists have actually made the task rather easy for all those who have joined us today. We have very, very interesting questions in the chat box, and let me take them one by one for the paucity of time. We'll be quick now. And Dr. Vismay wanted to know as to how long we should continue dialysis before deciding renal transplantation. Dr. Rajiv, can you take it up? Do you believe it's mandatory to put the patients on dialysis before subjecting them onto transplantation?
No. Preemptive dialysis, sorry, transplantation as is probably ideal. There is a contrary view that if they do not go through a hemodialysis, will not really value the transplantation as well as otherwise. But I do not subscribe to that the thought process. I think if the GFR is somewhere between 10 to 15, if you have a live related donor, I think you should go for a preemptive transplantation. The complication rates are definitely lower, in my opinion. And uh, I would really go for that. Having said that, practically, is it possible? No. Hardly ever, maybe less than 10% of patients go for a preemptive transplantation. Most of them actually go through a session of dialysis. If you're already in dialysis, I encourage them to get a transplantation done as quickly as possible, because longer you wait on dialysis, you will encounter some of the complication. Of course, now hepatitis C can be easily treated, but otherwise, other issues can crop in. And I think it's better not to waste too much of time if you're really going for a transplantation. Do it as quickly as possible.
So this was question actually asked by Dr. Vismay. So thank you very much for answering that. Dr. Ravi, Dr. Ashok wants to know, does dialysis really improve mortality outcomes considering the kind of advancements we've had in the recent times? Do you personally believe that has happened already?
Yes, definitely. If you compare the three modalities of renal replacement therapy, that is CAPD, hemodialysis, and transplant. So transplant is the best. But if you compare even in hemodialysis and CAPD, they are equal. I take it as equal. But in hemodialysis, there has been improvements because of the water quality, because of the ultrafiltration controlled machines, because of the different types of filters we have now with high cutoff value filters, and because of more understanding in the patients, more education of the patients and their cooperation. I would like to highlight here is one is that there is no limit of survival. You can't label that this is the limit of survival, 5 year, 2 year, 10 year. You can't label. We have so many patients more than 10 years. So it
Yes.
is just understanding the therapy. What you have to understand is the most important thing in hemodialysis is more dialysis and more diet. The concept of less dialysis and less diet is wrong. You have to eat more, you have to do more dialysis. And I tell my patients to have at least 4 eggs every day. There should be no restriction on protein intake. It should be 1 to 1.5 grams a day. But that will only be achieved if you have good appetite, and that will come if you do more dialysis. So I think that is a very important concept to understand.
Dr. Shailesh, Dr. Verma wanted to know the end of life care in patients receiving dialysis. When to discontinue dialysis? You have typically a patient on hemodialysis, and in spite of everything, you've taken all the measures, but maybe because of age catching up or some comorbid condition not allowing the patient to do well. Do you face this kind of dilemma as to when you have to tell to the family that enough is enough? I think let's call it a day and then probably do away with dialysis.
Yeah, so I have actually come through few situations like this, but that basically they are the patient who are having neurological issues and having some psychiatric diseases where they are really not doing well, they are drowsy, not able to move. So in such kind of cases, yes, there can be a way they are even in spite of dialysis, their sensorium is really low. They are having severe pain. They are not able to means not coherent at all. So such kind of patients, I have actually told ki yeah, now that is, but it is a family decision. I never tell stop the dialysis. We should always convey that these are the things which we can. It should be combined decision.
Right, quite agree, because this is a very, very difficult, and as I say, we so very often face this dilemma. Dr. Preeti, you have very beautifully had answered what Dr. Ansari wanted to know as far as the volume status is concerned, but Dr. Devya wants to know from you, in patients receiving dialysis, is insulin the only thing to manage their diabetes, or do you employ the newer drugs which can be safely used? Because we know giving drugs like the sulfonylureas can be quite tricky with their extended half lives in patients on dialysis, and so many times the patient is first diagnosed to have chronic kidney disease is when a diabetic stops requiring anti-diabetic drugs and lands up in the emergency with profound hypoglycemia. So what is your take on management of diabetes in patients on dialysis? Dr. Preeti, that one is for you. I think we lost Dr. Preeti. Are you there? I think maybe she has lost her connection, or maybe I can request someone else to take it up for us. Ravi, Dr. Preeti, are you there? Can you unmute yourself?
Okay, I'll take the
All
question.
right. Yeah, please, Ravi. Yeah.
Yeah, so the most important thing we have to understand is as renal failure advances, the half-life of these drugs increase, and sulfonylurea should not be used. Insulin is the best modality because we know we can predict the duration of action. We have short-acting insulins which last for only 3-4 hours. We have insulins which last for 12 hours, and where the risk of hypoglycemia is less. Then coming to oral agents, we can use DPP-4 inhibitors. We can use vildagliptin or linagliptin. Otherwise, very short-acting agents for postprandial control, like voglibose, can be used, though the use should be limited because it can also have side effects. So these are the commonly employed in certain patients where the sugars are very high. Still, they are on short-acting sulfonylurea may be used cautiously. So these are the modalities which we are using in our patients.
Oh, very right. I think that's a very interesting question, and Dr. A. Joshi wants to know, is statin therapy useful after initiation of dialysis? That's very interesting question, point which he has raised. Venkatesh, would you want to take it up? You see, the basis of this, I think maybe why he's wanting to know is there were trials starting from the 4D trial with torvastatin, and then the Aurora trial with rosuvastatin, and then we had the Sharp trial with the ezetimibe and simvastatin, which said that probably it is not worthwhile initiating the patients on statins if they have not already been started on statins at the time of initiation of dialysis. While if they were already on statins, it is perfectly fine to continue them in statin. But to starting a patient on statins after he or she has reached the stage of dialysis is a bit controversial. Dr. Venkatesh, can you take up that controversy, and do you really do that, especially in patients who have a very, very high, you get the lipid levels done, the LDL is something like 180, 200, the triglycerides are very high. Would you want to treat or go by the traditional guidelines?
Usually at the start of the dials, we get a lipid profile done. If it is way too high, as you told, we start the statins. Else we don't. And if the patient is already on statins, we continue it as per the guideline. Else, if the patient has more risk factors for atherosclerotic cardiovascular disease, like he's a diabetic, hypertension, which we usually see, and if the lipid profiles are very deranged, we can initiate statins. Low dose statins can be used, like 10 milligram of atorvastatin, which we are usually using. We can use it. If the lipid profiles are normal, to get any extra, we don't get any extra benefit by initiating statins in a patient who is just getting started on dialysis.
Right, and I think the one of the interesting question comes from Dr. Vidyut, who wants to know: are there any survival differences between patients started on hemodialysis vis-a-vis those who go in for a kidney transplantation? Now, we heard that from Dr. Rajiv. Can we have Dr. Shailesh's viewpoint on the long-term survival benefits the difference between the two modalities, be it hemodialysis, the dialysis or transplantation, and because Dr. Vidyut wants to know with the effective strategies, we are able to curb the menace of infections in a majority of the cases, not the way we used to experience them and encounter them a few decades ago. So, what is your take on the two, long-term survival?
So my take still on long-term survival is that if anybody has a good transplant done, I think they have a better survival if everything is going on well. But definitely with the newer dialysis, all the forms we have, everybody I think have a patients who are actually on 10, 15, 20 years on dialysis. So if the transplant is a modality, if anybody has a donor, I think I will prefer that. Mortality wise, it is difficult to generalize. Mortality wise, also transplant has been proven to be better than the hemodialysis, but not like we have to choose the patient. That depends upon the individual patient, that the things can be different. I can choose that, yeah, this patient has these problems, I will choose him for dialysis better than the transplant. That is a possibility also.
Dr. Ravi, Dr. Abhishek wants to know about your vaccination strategies. What kind of vaccines do you advocate to your patients, and do you believe they make a big difference in the practice?
So the vaccines we commonly use in dialysis patients is hepatitis B vaccine. That is the first vaccine because their blood is circulated and they are in a dialysis unit where they can be exposure to hepatotropic viruses, and hepatitis B is a vaccine preventable disease. So what we use is a double dose of the normal, that is 40 microgram or 2 ml in 4 doses, that is 0, 1, 2 and 6 months. The second vaccine we use is a pneumococcal vaccine, conjugated pneumococcal. Now, pneumococcal Prevenar 20 is available. It's a conjugated vaccine. It's a single shot intramuscular. We use that. And third is the tetraflu, the flu vaccine we are using. That is given every year. And the fourth is the Shingrix, which is recently available for zoster, and we use 2 doses, 0, and the second dose can be anywhere between from 2 to 6 months. So these are the vaccines we commonly employ in our patients.
So recently, we have the benefit of the Prevenar 20 vaccine, and now
20, yes.
the job has been made quite easy. We just need one vaccine against pneumococcus. And then I think we also, as nephrologists, are mindful of the increased risk of infection. So we ensure that they receive their annual flu vaccine, and wherever applicable, that is over the age of 50, the herpes zoster. I think this is a very important message which we have discussed earlier as well. It's our moral responsibility to ensure to try and prevent whatever we can prevent via these vaccinations. Dr. Rajiv, the last one, I was actually wanting to ask Dr. Preeti. I think he may have logged out inadvertently. Preeti, are you there? So that we would want to hear you talk about the control of blood pressure. Otherwise, Dr. Rajiv, can I request you to take it up? The blood pressure is rather difficult to control in our patients on hemodialysis. So any suggestions, any tips as far as the management is concerned?
Yeah, the blood pressure targets are slightly different for hemodialysis patients compared to general population or even CKD population. There's a bit higher target, maybe 140, 90 may be acceptable, even though it has not been completely standardized. So the most important factor for the control of blood pressure would be volume control. This is probably the most important one. We utilize clinical judgment as well as BCM to fine tune, and there is something called uh, progressive decrease in the what you call target weight so that you achieve the blood pressure control. And that is number one. Number two is antihypertensives. Typically, about 2 to 3 drugs definitely they need. And carvedilol seems to be a one which is probably better tolerated. It's not removed by the hemodialysis. I would rather use it if you especially have cardiac problems. Otherwise, I don't think I have any preferences for this any particular antihypertensives. Depending on your pulse rate and your what you call degree of hypertension, you could use calcium channel blockers, beta blockers, and so on and so forth. But primary focus should be on a volume control. I think that should be the focus.
So I think it can go on. And as always, I'm enjoying this discussion, learning a lot from my lovely, wonderful friends and colleagues. So I think the time does not permit us to go on any further. My last one to Dr. Shailesh. Shailesh, the way I asked Dr. Rajiv about the difficult to control blood pressure, the other problem which we experience very often in our patients, and so many times that proves fatal, is the risk of hyperkalemia. So have you started using the novel potassium binder now available in our in country, and how do you really incorporate it into your dialysis practice?
Yeah, so I have started using, but not much in dialysis practice. But in most of the patients who are on Kerendia or means on Finrenon or other drugs, or they are having hyperkalemia due to some other reason. So dialysis also, what I usually use is use for 5 to 7 days and then recheck the potassium, but not like I have not been still using it for a month long or 2 month long and then seeing are they helping it. So I think it has been recently come within few 6 months. I think it has been launched. So I have started using from 2 to 3 months. So still now I am finding it a good drug as well, controlling the.
Great. Dr. Rajiv, your last minute,
Yeah.
and I think Dr.
So,
Preeti is
no,
back,
no,
and we.
we have a few patients who get high potassium more than 6, especially when you're doing it when a gap of 3 days. And I started using that. I just looked at the other day, the third day of whatever the third day of dialysis. I give them what we call 10 grams twice a day. I find that the potassium is definitely lower than what it used to be earlier. So in those patients who have a high potassium more than 6 on a gap of 3 days, who are on three times a week dialysis, I do recommend that. I think it works very well.
So, Dr. Preeti, if you are back, then maybe this one is for you, the last one. Otherwise, I think we'll call it off. I think over to you, Dr. Mithlesh, for the concluding remarks. And one more time, I think maybe Dr. Mithlesh, you can let us know how many finally logged in today for the encouragement of all those who were present. The last I heard was there were about 1400, or was the final number more than that as well? So I think this is one. And then once again, I would like to thank Intas, spearheaded by Mr. Amit Arora, and I think the kind of great service which they are doing by propagating the knowledge of CKD management across the country. And I think this is a great responsibility which we as nephrologists would want to shoulder. The beauty, as always, is that no branding, and it's a purely an educational event which Mr. Arora, ably assisted by Mr. Gaurav Khanna and Dr. Mithlesh Naik, who do a great job as always by pitching in and doing all the groundwork, facilitating the dissemination of knowledge. So thank you very much once again from the core of my heart, and then over to you for the concluding remarks. Thank you once again, all my dear friends, the panelists, elite
Thank you.
panelists,
Thank you.
Thank you. Thank you very
Venkatesh.
much.
You
Thank you.
did a
Thank you
good
so
job
much. Thank you so
execution.
much.
Preeti,
Thank
we've
you,
been
Dr.
waiting to listen to you, and you've deprived us of your
So I
pearls of
was
wisdom.
I
So
was here. I just logged out. Internet was the issue, but I logged in back.
yeah. So anyway, we miss you in between. We had some very specific questions lined up for you, but then maybe the next edition, maybe we'll want to
Sure.
rope you again. Thanks,
Sure.
everyone.
Thank you, Dr. Kuller. So it was uh, a wonderful session of discussion. So I really thanks all the panel members for providing such a engaging and meaningful discussion. So first, I would like to thanks Dr. Venkatesh for providing a clear overview of dialysis, which made our physician to comprehend the discussion later on very easily. I would also like to thanks our panel member Dr. Rajiv, Dr. Sailesh, Dr. Ravi, and Dr. Preeti for providing very engaging, meaningful discussion and sharing your expertise with us. And lastly, I would like to thank Dr. Dinesh Kullar, sir, for creating such an engaging platform and sharing his wisdom with all of us. I would also like to thank our tech support team for creating this platform and making smoothly performance of the event. So once again, thank you each and every one of you. With this, uh, good night and take care, everyone.
So I